So the key question is, should I stop here, or did we really need contrast-enhanced ultrasound for this kind of disease? If we start and look at the MRI image and CT image, we see immediately that it's very difficult to beat this modality. I mean, on the MRI, we see very nice the subclavian stenosis, the vertebral stenosis, and the internal artery stenosis. Also here in the CT, we see the stenosis as the external iliac artery, the internal iliac artery. Could we be better or not? That's the key question. So in this case, if you think about stenosis, we have to make a decision. Does this patient really have got a stenosis? And we have to discuss it. What will be the best treatment? Should it be stenting, surgery, or if there's an occlusion, no treatment? There's a couple of new options. The most used option in this case is contrast-enhanced ultrasound. Normally, the examination, we start with the grayscale carotid artery, followed by a color Doppler. Look about the scanning angle, how does it change the coloring of the vessel. And now I repeat the examination by using the contrast-enhanced ultrasound setting. Did you have seen this stenosis here before in the color Doppler? I think most of us will probably haven't seen it. But you see a probably very bright vessel without overriding artifact and without limitation to the scanning angle. It's up to you whether you would like to have just the contrast, the pure contrast signal on the right side, or whether you would like to mix it with some background information. I personally prefer the background information because then we have some anatomic landmarks on the image. So for the carotid artery stenosis, it's essential to know, is it really a stenosis? How high is the degree of the stenosis? Or is it maybe a pseudo-occlusion or an occlusion? Everybody sees this high degree of stenosis with a soft plug on the ventral part of the carotid artery and also on the dorsal part. We have already seen by using the color Doppler that there is a high velocity inside. And if we measure inside, we got a velocity about nearly 5 meters. This means over 90%. So everybody confirm this is a high degree of stenosis which should be treated. So will be there any benefit if we now inject additional contrast? I would like to show you this case. So your contrast has arrived. You see the pre-stenotic flow, intrastenotic flow, and the post-stenotic flow without artifacts. Did you have seen the vascularization of the plug? No, probably. So for future, you have to think about whether vascularization of a plug is an indicator to make the decision whether a patient maybe should get earlier under surgery or not. And you see probably the complete extent of the kind of stenosis as I've shown you here. Look again, you can see small bubbles here which appear in the wall, enter the stent graft, enter the plug. On this part of the plug, there's no cross uptake. And if you magnify it, you can see where's the entrance. Is it from the vessel? Some arrive from the vessel, but also a couple of bubbles arrive from the wall. On the other side, you have to exclude whether it's really an occlusion or not. So the question in this patient was, does this patient have got an occlusion of the ICA, yes or no? Take your time and look carefully. In the next case, I will ask you again. I'll show you the color Doppler image. Is there any flow on the ICA, yes or not? If there will be no flow, our vascular surgeon will not treat the patient because then the vessel is occluded. But if there will be a minimal flow, this patient has got a risk to develop strokes again. So what's your opinion? Is there a flow or not? because this is the point where you normally stopped during a normal examination. And now you have to make a decision, will there any need for contrast or not? I repeat the examination. This is the external iliac artery you see, external carotid artery. And here you see a pseudo-occlusion of the ICA. And if you ask me how long is this pseudo-occlusion, you see the complete extent of the pseudo-occlusion. And now we find a pretty good indication to treat the pseudo-occlusion because you could prove it now. On the other side, a very similar case. By using the Doppler, we could see a nice flow in the external carotid artery, but in the internal carotid artery, we could not see any flow. By using the power Doppler, we get the similar results. And finally, if we use the contrast, we say there is a minimal flow here, but the rest of the vessel is completely occluded. But keep in mind that you also have to shift the probe in 90 degrees, because if the flow will be on the right side of the vessel wall, you will miss it if you're on the center of the vessel. After making the decision, you have to think about what will be the best therapy for your option. Should it be open surgery or should it be stenting? This patient undergo after open surgery. You see the dilatation of the bulb here. You see some plaques here. The question is, how does it look now by using Doppler or power Doppler? I mean, power Doppler, you see more of the bulb. But if we now compare this by using the contrast setting, you see pretty good the complete extent of the bulb without the artifact. You see the soft plaques here, see the external carotid artery, internal carotid artery, the soft plaques here on the wall. But overall, the results are fine without the limitation as we've seen by Doppler. On the other side, there also could be appearing complications like hematoma. And the question is this now a hematoma which have got an active bleeding, yes or no? Therefore, we just look again in the axial plane. We see just adjacent to the carotid artery hematoma. And probably it's very difficult to rule out by using the Doppler to say that this hematoma doesn't show any contrast uptake. If you repeat the examination, you see the patient has some problem with the heart because contrast arrived for the first time in the jugular vein instead of the carotid artery. Then you see the hematoma is complete black. It doesn't show any contrast uptake. And of course, you have got a window up to 2 minutes and you have time to scan the complete hematoma. Still black. And if I look later, still black. So no active bleeding, and this also means no treatment of this hematoma. If you think about stenting, you have also keep in mind that sometimes patients suffer from in-stent stenosis. So if you look carefully at the stent graft and I ask you, did you see any stenosis? You will probably say you need the Doppler. I give you the Doppler and power Doppler. And you have asked yourself again, did you see stenosis? Finally, I measure the velocity. Unfortunately, we have got a velocity about 250 centimeters. The problem is we didn't know what was in the past, how high was the velocity. So, did you see a stenosis now or not? If you only rely on the velocity, there seems to be a stenosis, but it's not clearly visible by using the Doppler or power Doppler settings. If I repeat now the examination by contrast, you see that here something is missing. Normally, contrast should fill the complete stent graft. Also, if you look at the axial plane, about 50% of the perfused lumen doesn't show any contrast uptake here. If I magnify the image again and scan the complete stent graft, you see how much lumen is missing with contrast uptake. That means this patient has got at least 40% of the lumen is a stenosis inside. And these kind of stenosis are very easy to miss if you don't use the contrast enhanced ultrasound. This patient has got a ICA stenosis on the right side. We see it also on the MRI examination. This patient was treated with a stent graft. And the question is, does the patient has got now an in-stent stenosis or not? By using the Doppler, it seems to be that here we have some high velocity because due to the changing of the color. And the question is it now a high degree of stenosis or not? If we measure inside, we got a velocity about 400 centimeters. It's a very high degree of stenosis. And if we repeat the examination by contrast, we see that this patient has got an in-stent stenosis on the ventral part and also on the dorsal part of the stent graft. These are artifacts from the calcification of the carotid wall. You can also measure the distance between the perfused lumen and the original lumen and can make a correlation in order to measure the diameter stenosis. The question is, could we see it by CT? Same examination, same patient underwent CT. I think it's a big challenge to say whether this patient has got an in-stent stenosis or not. And finally, the patient undergo intervention and it confirmed the in-stent stenosis. The patient received another stent and afterwards you see it looks better, but I'm not sure whether it was really a successful treatment. Dissection are not so often. Often they will ask you, what about the perfused lumen? Is there any perfused lumen? Are there two perfused lumen, yes or not? If you look carefully at the grayscale, you see that here is something wrong on the dorsal part of the carotid wall here. The question is this now a hypertrophy of the IMA, or is this just a dissection? By using the Doppler, it seems to be that here something is wrong in the vessel. The same is confirmed by using the power Doppler. And also, if you look very carefully at the power Doppler, it seems to be that here is some flow. In the next step, we inject contrast. You see dissection of the carotid artery as seen it here. And if you wait, you see there the contrast is uptake. You see the complete extent of the dissection with the true lumen and with the false lumen here. Sometimes we have also rare cases like fistula or aneurysm or tumors in the carotid arteries. This was an old woman which undergo central line access. Unfortunately, it was very difficult. And afterwards, the patient suffered from problems with the heart. So the question is, was this a fistula, yes or not? If you look at the grayscale, it seems to be here's a connection between the carotid artery and the jugular vein. By using the color plot, we see already this kind of aliasing, very similar as I've shown you this in the aorta and the IVC. And if you now compare this, you see immediately what was the angle for the intervention. It was not the perfect angle, probably. In order to avoid this complication, they should have got other access to the jugular vein. What about this patient? This patient also undergo central line access. Unfortunately, it was also a little bit difficult, and we should prove whether it was a fistula or not, but we see just between the jugular vein and the carotid artery hematoma. We also see some flow in the hematoma. And now the question is this a pseudoaneurysm or not? So we could see that the bubbles appear very fast, much faster in comparison to the jugular vein. In the beginning, there was no connection between the pseudoaneurysm and the jugular vein. So this is a kind of pseudoaneurysm after intervention of the jugular vein because they puncture also the carotid artery. And afterwards, they have got this hematoma with a pseudoaneurysm. Also here you see the complete extent of this aneurysm. And this was also treated under vascular surgeon. Aneurysm of the carotid arteries are rare. You have to exclude what is the diameter of the aneurysm and does this aneurysm have thrombotic changes. This is the external carotid artery This is the internal carotid artery. This is a common carotid artery. By using the Doppler or power Doppler, we see most of the part of the aneurysm. But the question is how much thrombotic changes are in the aneurysm. Also here, if we inject contrast, you see the complete extent of this aneurysm. With the internal carotid artery, external carotid artery, you see some branch here. And if you shift the probe, you see about 30% of this aneurysm have thrombotic changes in the wall. This was a young man which sent to our department because his outstanding doctor said there was a high suspicion of an aneurysm of the common carotid artery, but remember these are really rare cases. So maybe it's a thrombotic changes at the wall here. But if we look at the Doppler, we could also detect some flow inside. So you can say probably this is not an aneurysm, it seems to be just a tumor. If you look at the perfusion, you see this tumor have got an immediately contrast uptake like the carotid artery. So this was a carotid artery body tumor. This is just adjacent to the bulb here. Here's the bifurcation between the external carotid artery and the internal carotid artery. If you have got this carotid body tumor, they compress the vessels, and you have to think about treatment. You see the perfusion of the tumor, but if you look at the perfusion by using the contrast, you see how much this tumor show. Very fast uptake in comparison to the normal tissue. A lot of vascularization. There's a couple of options how to treat these body tumors. Either you do an embolization with onyx, or the patient have to go under vascular surgeon. In this case, we make the decision that we would like to treat it with onyx, so we use a protection system in order to avoid any stroke, and afterwards we inject in the tumor some onyx glue. After treatment, no perfusion of the tumor, and of course we also would like to prove it by using the grayscale. You see the white dots here inside, that's the glue. By using the Doppler, we couldn't see any vessels inside. Finally, repeat the examination with the contrast setting. And also here you can say this was a successful treatment because this carotid body tumor doesn't show any perfusion anymore. So you could immediately see the results of your intervention by using this kind of technique. So you have seen there's a couple of indications for the vascular. For the guidance, the recommendation was carotid artery stenosis or follow-up after carotid stenting. There seems to be also some advantage regarding dissection or complication after vascular intervention. I don't speak so much about carotid plaques because otherwise I need another half hour in this session. So thanks for attention.